Well, I'd like to thank my partners here for coming in and providing us with several cases. And we're going to go through some different discussion topics and then hit some of the question and answers at the end. Just as an introduction, when you're looking at the hallux valgus and first ray problems that we have with hallux valgus, one of the issues that we wanted to address was this essentially multiplanar deformity that happens. And so we're going to go through a system technique with this. And so when we look at this transverse plane, we're looking at the IM angle and reduction of the IM angle. And you can see in the video that there's also a frontal plane reduction that's occurring. And then lastly, we want to look at the sagittal plane and make sure that as we're performing this fusion, we're not plantar flexing the first ray, nor dorsiflexing the first ray, nor shortening the first ray. So, when we looked at this, we tried to come up with a system that would give us a correction in all three planes, but at the same time, we wanted to minimize how much of the first TMT joint was being resected. And so the engineers at Crossroads came up with this cut block and then essentially a sequential system of treating this deformity that minimizes the amount of bone that you have to take at the first TMT joint. So you can see in the video that, again, this is a demonstration of after the cuts are performed, you're reducing the rotation as well as the IM angle. Oh, shoot. And so the last thing that we like to focus on is the compression or healing. So we've gone through these different actions in order to correct our deformity. And then what we want to get is a good fused joint at the first TMT joint. And we use a staple plate construct because we believe that that provides the best stability in order to achieve this. Some of the other aspects of this system after you've gotten your correction are what is termed the 4D rack block or just rack block. And what that does is it provides compression at the first TMT joint as well as provides maintenance of your reduction. And then you can place cross K-wires to hold your first TMT joint while you're placing your medial plate and staple as well as other screws. One of the other aspects of this system is the anti-drift bolt, which is a screw that's specifically made to fit into the plate and catch a shoulder of the plate in this area and then provide maintenance of this intermetatarsal reduction. So what we've tried to do with this is, again, to keep it very simple so that there is not only simplicity, but also consistency with this. And again, the key to this is twofold. One is the cut block, and we'll go through that a little bit as far as how that's utilized. And then essentially the clamp that provides your intermetatarsal correction, but also provides you maintenance of reduction of your coronal plane deformity and rotation. So again, I discussed a little bit the anti-drift bolt that provides maintenance of that reduction. We don't see it as something that produces reduction, but it helps to maintain your reduction after you've already obtained your good reduction. Then also looking at the plate staple construct, when you look at this biplanar plate construct versus the staple plate construct, we had 152% greater static strength and stiffness versus a biplanar or a two-plate construct, and then 60% greater life cycle fatigue strength versus that biplanar construct. Again, I alluded to the anti-drift bolt, and it's a special construct that catches a lip of the plate with this specially made shoulder of the bolt. And what that does is it keeps the bolt from being prominent over the medial aspect of the foot. So surgical technique, again, Scott Renner is usually the one that's giving this portion of the talk, and so he gets into the C4, but it's cut, compress, and then compression forever. And what we mean by compression forever is when you put this nitinol staple in there, it's going to continue to provide compression across your construct. So again, cut, this is your guide that is specifically made for the first TMT joint. Then you're going to provide a correction, which is going to be rotational as well as the intermetatarsal angle. So this, one of the keys that you may not see in some of the portions is this tool right here. You're able to rotate and correct your coronal plane or your rotation. You then intermetatarsal angle, then you can pin through these holes. And then again, you reverse your cut block, cut your cuneiform, and then you compress with your rack block. So this is one of my patients, and this is a little bit more complicated deformity that you see here. There's, of course, the obvious bunion, but in this case, you have fairly significant metatarsus adductus, and so the intermetatarsal angle was not that great. Other complicated portions of this case was that she had midfoot arthritic change. And so we had to come up with a plan on how to address the midfoot arthritic change at the second and third tarsometatarsal joints, but also how to provide correction. And so we utilized the DynaBunion system in addition to some freehand cuts to the second and third metatarsals. So she had, can you go to the previous slide, Scott? She had some injections into the midfoot and failed those injections over about a 2-year period. And then you can see on the MRI here at the tarsometatarsal joints, fairly significant arthritic change as well as some bony edema. And so we couldn't just do a distal metatarsal osteotomy. You could in fusion, I guess you could, but what we elected to do is provide an entire midfoot fusion. And so what we ended up doing was angular cuts of the metatarsal bases. We did end up doing those freehand, so we did those first, and then we addressed the first TMT joint with the DynaBunion. What you don't see here is that after we had performed those cuts, instead of placing the intermetatarsal clamp between the first and second metatarsals, we actually came over to the fourth metatarsal. And so what that did was provide us correction of not only the first ray, but also provided correction at the base of the second and third metatarsals. We ended up doing a minimally invasive Berg technique for an Aiken in addition, but did not end up doing a medial eminence resection. Also on this case, we did do a modified McBride, so it open adductor release and pie crusting of the lateral capsule. At this time, I'd like to release the controls over to Dr. Perler, and he'll also go through some cases. And again, at the end, we'll have some time to go through some more things.
Thanks, Dr. Sean. I think I have control. I'm having a hard time advancing. There we go. Okay. So basically, what we're doing is we're each kind of taking an aspect of this system that we really like. And what I was going to really focus on is the nature of the cut guide. And I think that that's one of the hidden gems of this system, is the fact that you're uncoupling the cut. And I'll kind of have some examples of how we go about doing that. I don't see where I'm able to, yeah, there we go. The other thing that we've heard about is the battle of the dimensions. We've heard one system kind of refer as the 3D bunion reconstruction, and now we have the DynaBunion, which is the 4D reconstruction. You kind of saw the justification of the fourth dimension that they were talking about with compression. But what I kind of want to focus on is the journey that I've had as a Lapidus surgeon. I've been doing Lapidus for over 18 years, and I'd say I did a decent job of it. I definitely got down to the point where I could do a Lapidus in about 45 minutes and was okay with the results. But then back in 2016, we started seeing some new data from Larry DiDomenico and Paul Dayton talking about the frontal plane, and it kind of went back to the original description of Lapidus, and that was that we were all missing something. And you know, there's a famous quote that says, most of us fail to see what we are actually looking at. And that was really true, at least for my experience with Lapidus, is I felt like I left a lot of correction that could have been achieved on the table by not really paying attention to the frontal plane aspect of the sesamoids. We all, at least I believe that if you got the IM reduced, that the sesamoids would magically come back, and we found out later that it doesn't really work that way. And that's where that 3D or third dimension comes in to play. So the frontal plane really does play a role. Can we go to the next slide? So to kind of take this further, I wanted to look at total ankles. And I know that this is kind of a weird offshoot of this, but this is really kind of at the basis of how these cut guides work. So there's coupled and versus uncoupled cut guides. So when we look at this ankle on the left, and we know that we're going to correct it at some point, when you go to do your cut resection, you're going to do a coupled cut because it just makes sense that you're going to have two parallel surfaces. But what happens when you get an ankle joint or joint deformity that's out of congruency? And it's not easy to correct this with a coupled cut mechanism. We'll go to the next one. And so here's just an example of a cut guide, you know, on a rectus ankle, in the next one. And this is basically what you have to do. If you're going to couple your cut, you have to take an ankle out of deformity to get it rectus before you put a coupled cut guide on. And we have jigs that we use to accomplish that. And that's kind of how we got started with the very first instrument at Lapidus, is that you're using a jig to make the correction, and then you use a coupled cut guide to make the cut. And it's very similar to this method of correcting an ankle replacement. So uncoupled cut guides, on the other hand, I think really come into play when you have these out of rectus ankles. And if you think about how we correct a bunion, if the first metatarsal cuneiform joint is rectus, it's just basically off angled compared to where we want the metatarsal to be. So what we end up having to do is to push the joint out of congruency, but into proper alignment relative to the second metatarsal. And then you're using a cut guide to achieve that. And we know that for a deformity like this, the best way to correct this deformity, if you can't get the joint realigned, is to uncouple the cut. And of course, now we have PSI to help us do that. But in general, this is how we treated or approached deformity in total ankle. And I'm going to now cross over to how this works with the Lapidus. So here's our total ankle, or our ankle that's out of congruency. And then we look over here, and this first metatarsal cuneiform articulation is congruent. It's just off kilter, you know, it's atavistic in nature. So there's this special ankle called the first metatarsal cuneiform angle, and it's basically a bisection of the second metatarsal, and then you take a 90-degree perpendicular to that, and that's that top yellow line. And then you draw an articular set angle off the medial cuneiform. And that angle difference is basically the difference between a straight metatarsal and our off-angle metatarsal relative to the second. So this wouldn't work in the case that Dr. Shawn just showed with the metatarsus adductus. This is assuming that the second metatarsal is in a rectus position. And then our cut guide is going to be swiveled to correct that by basically cutting the line in the cuneiform, which was that blue line. So on the left, what you have is our initial instrument at Lapidus that used a coupled cut guide mechanism. And so what you're doing is you're relying on the compression of the first and second metatarsals, taking the joint out of alignment, or at least out of congruency and into alignment, and then using a coupled method. Now, the problem with this is sometimes this cut guide wants to kick out medial, depending on the shape of that joint, because all joints are shaped different. There's probably 8 or 9 different types of articular patterns of that joint. And so the guide can actually want to displace medial. Well, if it displaces medial, you're going to take a much deeper cut. So what's nice about the Crossroads device is that there's a single cut line, and you're actually letting the deformity be the guide for the correction. So and it's very dynamic the way this works. And this is basically analogous to uncoupling a cut on a total ankle. So first we have the cut of the metatarsal, and that's with the guide facing distal. And then you're going to rotate the guide to face proximal. And now it's the guide is actually sitting parallel to the basically the long axis of the first metatarsal. Well, now you're going to push the metatarsal into the restored alignment and rotate it in the frontal plane. And what that's going to do is swivel the cut guide out of parallel to the navicular bone, and it's going to give you the set angle on the wedge, and that's very close to the blue line that I had showed you on the previous slide. And basically, by doing this, what you're doing is you're creating almost like an infinity point medially that you're pivoting around. So when you go to take your resection, you're resecting the most minimal amount of bone possible. And then finally, you have the compression rack, which is the fourth C, or the compression aspect to this. And the way I look at this is, I'm a cyclist, so when you do a correct and then cut approach, that takes a lot of force, because what happens is you're trying to swivel around a joint that is out of position, and you're basically relying on an extensive soft tissue release to be able to do that. And that's like riding a bike uphill. What happens with the Crossroads approach is basically you're taking a cut first on the metatarsal, which frees up a lot of ligamentous tightness. And now you're able to swivel that bone more easily into a corrected position relative to the second. And that basically swivels the cut guide. So in this case, I find that less force equals greater efficiency. And one other thing I was going to state is that the best way to prove that a stick is crooked is to set a straight stick right next to it, and then you don't even have to talk about it. And that's one of the reasons why Lapidus has always worked for me, because I just feel that the best way to correct a crooked toe is to keep the metatarsal straight and correct it at its base or at the chora. And the other thing that's really interesting just about that is I'm going to read a statement, and the statement basically came from an individual that I think totally fits with the approach that Crossroads has taken with the DynaBunion, and that's: conservatism and individualization is indicated for operative correction of a bunion, and no operative procedure is satisfactory unless correction of the metatarsus primus varus is accomplished. And that statement came from Paul Lapidus in 1934. So here we are with this new technique, basically replicating an original statement by Paul Lapidus. So this is my first case. This was a 54-year-old female, basically had failed conservative measures, and the correction was done using this, and this was one of my first cases. And I really, really appreciated the simplicity and in the way that the metatarsal was able to rotate into a better position without much force using the cross metatarsal clamp. So that was a big eye opener for me. And then I also like the medial facing hardware because I just feel like there's less skin irritation with it. The second case, and by the way, on that first case, I didn't have to resect the medial eminence. And as far as lateral release, I do lateral releases, but I actually do them from a medial based incision, and I use a Maglamry elevator very, very carefully across the metatarsal phalangeal joint, and just use it to unstick the sesamoid apparatus and the conjoined adductor. And I like that because I don't want any tethering on the medial side, or on the lateral side. So that's why I do it from a medial approach. This second case was actually a 28-year-old female who had a more traditional bunion surgery when she was 18, and she quickly had a recurrence, and we understand why that happens now, especially with the malrotated sesamoid. So what I like about this is it does show how little shortening you have with this guide, and we were able to achieve a really good rectus position. And just a couple things about the instrument Lapidus in general. One of the questions that people have about it is, hey, I heard it really increases OR time. And I told you earlier that it used to take me about 45 minutes to do a Lapidus the way I used to do it with my traditional resection. The instrument Lapidus does take longer, but what I have found is that I've become a much more efficient and reproducible surgeon. And so I feel like my standards have improved quite a bit since using the instrumented Lapidus approach. There are multiple incisions compared to my traditional approach, but to me that's okay because I'm achieving a more optimal position in exchange for those multiple incisions, especially with the cross metatarsal clamp. In terms of metatarsal shortening, I think really by uncoupling the cut, you're reducing the amount of metatarsal shortening. I believe it's 1.6 millimeters versus some of the competitor cut guides that are closer to 5 or 6 millimeters of shortening. There's also, some people that don't, I guess, have concerns about proprietary hardware. And I think what Crossroads has done is they have lots of different options for hardware fixation, and you're not really stuck with one, and you can kind of go by what's best in your hands approach. A lot of people say that this is a generic approach, and I wholeheartely disagree with that. I think it's very individualized, and like you saw, every one of these cut guides functions based on the patient's individual deformity. And then finally, there's the concern that these instrumented Lapiduses are technically challenging. And what I would say is that Dr. Shawin and the team spent a lot of time trying to figure out where surgeons really struggled and have really made the user experience on this quite easy. And that's why I put this thing at the bottom saying, making bunions fun again. If you haven't tried the system, I highly encourage to give it a try because I think you'll find that it's a very smooth system and will give you great reproducible results. So with that, I'm going to hand it over to Dr. Leland.
Thanks, Adam. All right, so Lapidus has been my go-to bunion operation for over 25 years, and I think one of the things that I really like about the DynaBunion system is it's encouraging surgeons to do the correct bunion operation, and that's important. And it's not only encouraging the use to do the correct operation, but I think it's encouraging and enabling people to do it properly. Early on when I gave talks, I would always show the case examples of things I did great. And I think in some ways it's more helpful to share dirty laundry and show things that maybe didn't work so great, and how the DynaBunion can help with those problems in the future. There we go. Okay, so this was a younger woman with a very hypermobile first ray, and a relatively straightforward bunion. And if you could advance for me, please. Great. And so on her first side, she had a Lapidus procedure, and this was for many years. This was my standard fixation, usually 3 screws lagged across the first TMT and the intermetatarsal base. And when I got done with this intraoperatively, I thought I had what I thought was a pretty good correction. And when I look at you can advance it. When I look at my fixation, I'm old enough to remember when cigarettes had commercials, and this was one I'd rather fight than switch. And I had no desire to switch my bunion technique, my Lapidus technique. I'd used screws for 25 years. Screws served me well. But there was a little bit of a problem with the system that I was using. If you can advance it, Scott. The problem is nothing keeps you honest like follow-up. And despite what I thought was a good initial correction, upon subsequent follow-up, the deformity recurred. And the part that I think I missed out on was the rotational deformity. And if I think back critically and I look critically at hallux valgus corrections I've done via the Lapidus procedure over the years, ones that I've looked at where subsequently I haven't been thrilled with the long-term result, I really think I've missed on the rotational component. And not only has a DynaBunion given me a good system for systematically thinking about correction, I think it's really giving me more, I wouldn't necessarily say insight, but recurrent insight as to how the rotational component of the hallux valgus correction is important. And while her opposite side that lost some correction is currently asymptomatic, when it came to operating on her contralateral side, I went with the DynaBunion system and feel a whole lot more confident in subsequent radiographs. It's borne out that her reduction has been well maintained. All right, next one, please. So this was a woman that quite some time ago I operated on for a pretty significant hallux valgus deformity. She had had a dislocated second MTP joint, and in cases like this, as you well know, the medial capsule is completely dysfunctional. It's shredded, so you really can't rely on any soft tissue correction in these cases. And so underwent a Lapidus as well as second metatarsal shortening. And originally, just like in the first case, I had a pretty good correction. However, 3 years later, she came back with some recurrent deformity and was complaining of some pain. So, you know, I think one of the benefits of the DynaBunion system is it's trying to make us better surgeons. And, you know, I think as surgeons taking care of foot and ankle problems, if I wanted to have good results, I'd do, you know, simple robot total knees. But, you know, those of us that take care of hallux valgus deformities certainly know that this is not necessarily always an easy operation. And I think the DynaBunion is giving us a tool to hopefully improve our long-term success. So when she came back, this was, and please advance, Scott. So when I did her second operation, this was a revision operation taking down a fusion with the DynaBunion, and that's a very good application for this system in addition to a primary hallux valgus. I think if you look, the sesamoids aren't perfect in the redo cases. It's pretty hard to get the soft tissue component correct, but she's very much pain-free. Her deformity has been corrected, and DynaBunion worked well in order to accomplish this. So just some quick surgical pearls. I think one of the benefits of the system is the very limited bone resection, and others have talked about that. And I think it's so good. Well, does such a good job at minimizing resection that it's really important to make sure that you've taken enough bone off the medial cuneiform. And based on the obliquity of the medial cuneiform, there's times where, particularly plantarly, some of the cartilage remains. So I think it's really important after making the cut just to make sure that you've taken away enough bone that all the articular cartilage is gone. Little bit off-label, rather than using the standard anti-drift bolt, I like just using a regular 3.5 screw and lagging it. In my hands, I like being able to have better variability in the direction, and I like having more threads across the second metatarsal. Dr. Perler talked about Lapidus's original operation. If you read his article, one of the things that was definitely included in the original Lapidus procedure was an intermetatarsal base arthrodesis, and I think I do like that. It can be a little more challenging through a more medially based incision, which is used for the DynaBunion than the standard dorsal incision, which I used to use. But it's still possible to denude the joint. And once the cuts are made, reaching in the joint with small curved curettes is a good way to do that, to enable you to still get a solid arthrodesis across the intermetatarsal joint. And then lastly, if possible, cheating the fixation pins a little bit dorsally, and particularly during the rotational process, making sure they're dorsal, is helpful to allow you to keep the compression block in place while still applying the medial plate.
All right, let's see if I have the con here. Not yet. There we go. All right, so just kind of going over my bunion journey, if you will. I've been in practice going on almost 22 years now. I've probably used 8 to 10 different techniques over the years. And, you know, lo and behold, I think at this point I found something that's predictable, reliable, and definitely reproducible. And the thing that's, I think, important for any bunion that you're treating is you need to individualize the treatment. There's really no shotgun that's, you know, good for all of your patients. And, you know, through the years, I started off in my fellowship, I learned the Roger Mann technique. And then over the years, you know, learned the Lapidus technique. And I do use osteotomies, but I do find for more significant bunions that Lapidus is my go-to. So what are my indications for a Lapidus procedure? Certainly any instability that is clinically relevant, such as lesser metatarsal stress fractures, any severe bunion that is certainly not arthritic, any first TMT arthritis, and also for cases of stage 2C post-tib tendon insufficiency, where you have that medial column basically collapse, and you want to fuse that, and then obviously plantar flex your first ray. So some of the challenges that we're all familiar with can be non-union. That certainly can be a bad problem. Stability and strength of fixation is the key to union. It's the key to really healing any fracture or fusion moving forward. We know that it's a very deep transverse joint, and whatever fixation that we're using or basically how we're going to denude the joint or cut the joint is extremely important. If we look at some of the fixation options, you know, we've already had a little bit about screw fixations. Certainly can aid in compression of the joint, and it can be difficult at times due to the shape of the joint. And that may be one reason why, you know, using a cut block can be very helpful. Dorsal screws, one of the issues is it can tend to draw everything into dorsiflexion, and that's where you get the plantar gapping, which at times can be an issue. And also, you know, nowadays, when you talk about bunions, patients are very savvy. They're looking us up on social media, on the internet, and patients want to get the best outcome they can, but also get on their feet. So, you know, allowing early weight bearing is really going to be important. And maybe that's why screws are kind of lose some of their favor over time. So basically, the other thing to talk about is this medial screw to the medial cuneiform in the plate or alone. This is something I used to utilize a lot, but using in the DynaBunion, now we've kind of gone to the drift bolt, which is a little bit more distal. It's kind of staying out of the joint, and it allows the active compression to do its job, but also gives us some more rotational control as discussed previously. So, you know, this whole concept about, you know, the sesamoids and rotation, it's not really a new idea. You know, this old study going back to 51 and then more recently in 2009, we know if you're not getting the sesamoids in the right position, it can lead to a risk of reoccurrence. And for me early on in my career, I really was trying to rely on using the capsular reconstruction to kind of bring my sesamoids over. And sometimes you would bring it over and get it so good, and then you'd end up having a very tight first MTP joint. And if you can't move the joint, patients are not going to be very happy. So you have to get the sesamoids right. That's one thing we know for sure. And obviously rotation is extremely important. So just looking at some old studies, once again, lock plate constructs to help with early weight bearing and better load to failure than screws. And these are just some old articles looking into that. So, one of the things when you talk about what's kind of paramount to the whole crossroads system is, what if we could decrease non-unions and continue to compress even after we leave the OR? And that's one of the beauties about the whole concept of this continuous compression that leads to stability. And by getting this active compression, we're getting better results and getting better fusions. And this is something that in many of the Crossroad products, this is something I definitely am a strong believer. So let me just show you a couple of cases. Let me see if I can go back. There we go. 45-year-old hallux valgus has a plantar plate of the second toe. You can see that we did use an Aiken here, and this is probably one of my first cases I did with this, and got a pretty good result here. Here's a 52-year-old, also some hammer toe work. Again, good thing here. We got a great correction. The sesamoids look terrific. And again, finding this to be very reproducible in my hands. Here's a case of a 21-year-old. And this is a case that came in from elsewhere. Had what used to be a very popular proximal metatarsal osteotomy surgery that really didn't go very well. And this is a case that, even getting the pre-op sesamoid views, which I often do, the sesamoids were kind of out of position. And this is a case where, there's some parts of it that are going to be unpredictable because you're not sure you're going to get those sesamoids over because it's a revision surgery. And the previous surgeon tried to work with the sesamoids and just didn't get them reduced properly. So if you see what her pre-op looks like, this is going through the system using the cut blocks. A lot of times I'll denude the cartilage myself. I won't use the cut blocks all the time. I probably use the cut blocks entirely in about 20% of the cases. This was a case that it was necessary. And then we're going through the system here and really working on reducing our IM angle, getting our rotation, and then getting our block in position. And then ultimately getting our stable compression plate in place. And then you can see here, basically, here's the fixation that we got. And again, the sesamoids here, really hard to get them completely rotated here. There's definitely some arthritis in that area. Obviously, you're not going to be fusing a 21-year-old doing a first MTP fusion. But ultimately, if you look at her correction here, you can see that it looks much better. And ultimately, she was very happy and her correction was good, even though we didn't fully get the sesamoids reduced. I think she got a great correction and clinically looks great, and ultimately was very happy from where she had started. Thank you very much.
All right, so thank you very much, all of our presenters. Some very good cases shown here. And I think that what you do see is, although this is one system, everyone has a little different approach to essentially how we utilize it. What Dr. Philbin said, he still does a lot of essentially correcting the cartilage and then using the system to provide some correction afterward. You can totally do that. They actually have a portion of the system that's made. You can still use the rack block and do your rotational correction utilizing what's in place, and then again utilize the plate and stable construct. And so they've really thought of, I think everything as far as how to utilize this. The other aspect, if you have a very atavistic medial cuneiform, there's secondary cut guides and there's secondary rack blocks to make up for whatever you cut as you're trying to get the correction that you need. So again, very well thought out. Do we have any questions that have been presented so far? I don't think.
We do not have any to this point.
Well, that must be because their presentations were so good.
Exactly.
How about our presenters? Are there any questions that you'd like to ask of each other as far as how they approach different aspects? How about doing a modified McBride? I think that I probably do it about 50% of the time. I do tend to make a separate incision in the first web space or over the second metatarsal and then reach over and do it. If there's any other, comments, I think that we had some previous comments about utilizing a maglamory and coming through, which I do many times with my distal chevrons. But any other comments on that?
I would say for me that in the past, and you probably never want to use the term always, but in the past, I always, with any Lapidus that I would do, or most bunion procedures, would always do something with the medial eminence, close the capsule, and then almost always make my, lateral incision with lateral release. And I would say that as far as the lateral release is concerned, I'm doing that a lot less than I used to. If I'm getting my sesamoids where I want with the aid of these tools and getting it reduced, then I often don't need to do it. I probably do it 20% of the time, or before it was 100% of the time. Medial eminence, I still do that most of the time, and but there are times where I leave that alone. Again, if I love where my sesamoids are, I don't really need to do any correction, and if there's not a lot of a medial eminence, then I may not worry about it. As far as using an Aiken, again, I think if I feel like if they have some interphalangeus, then or the toes just kind of going off that direction, I like to, as we call it, a cheater Aiken. I like to put that in there just to improve the position a little bit, but probably do that maybe 20% of the time.
Okay. Cool.
Yeah, and I was,
No, go ahead,
I was just gonna comment. I also do 2 incisions. So I do my Lapidus incision, and I have a medial incision, midline incision. I like putting scar tissue, if I'm going to put scar tissue on the side that we're trying to resist from stretching again. And usually there's a little bit of capsular laxity there. I agree. I mean, if I do the correction and the toe is in the perfect alignment and the sesamoids are in alignment and there's not much of an eminence, I won't necessarily make that incision. The less scar tissue there, the better. But if it's needed, I'll do that medial approach. I usually do kind of an L-shaped capsule incision. If they need a release, I'll reach across the metatarsal head with the maglamory and just basically pull the toe into a rectus position, holding the maglamory stable, and it just kind of does the release automatically. And then the other thing that I do is I use the DynaBunion, I think that's what it's called, but it's basically their suture button, and I'll put that in the metatarsal neck, and then I'll use that to reef the capsule medially. And I just find that if you need any additional correction of the sesamoids, that's usually how I can get it. And that would be my cheater. I don't typically do a lot of Aikens.
I think I wish there was a way of predicting with lateral releases which of the patients had that really thick adherent sesamoid metatarsal ligaments, because I think in those cases it still is important to do a lateral release. There's other times when it's very non-adherent, and certainly correcting it through the rotational correction is all you need. I use my lateral release incision to insert my IMA correction device. So I'll sneak it around the second metatarsal through my lateral release incision. So I'm not really making another incision that I wouldn't have been making otherwise. But like everyone else said, as time goes on, I'm straying away from my old habits and doing that less and less.
So all of you have done Lapidus or first TNT fusions for probably a combined 55 years. How often have you seen hallux varus after this procedure?
I'll go first. I would say I've seen it one time that I'm aware of, and I think that it was more overzealous soft tissue work that kind of led to it.
Yeah, so like overzealous lateral release capsule. Okay.
Correct.
I too have seen it one time, as far as after a Lapidus, and it was related to the lateral release. I do a fair number of Aikens. I tend to say the only Aiken I regret is the one I didn't do. So if I think about it, I tend to do it because they'll come back and they'll say, why is my toe still a little bit crooked? And I like to be able to yeah, I think that they'll drift back over a little bit with an Aiken if you overcorrect slightly. Probably about 50% on my medial eminence and probably again about 50% on my lateral release with these.
I would say that since I've been doing instrument Lapidus, I really haven't had the problem of varus. If I feel like that the toe is, sitting in a good position and I go to stress it medially, and I feel like it's just going to slip into a varus position, I won't touch the first metatarsal phalangeal joint at all. And knock on wood, I haven't had any occurrences of hallux varus. I did when I was doing Lapidus traditionally. Without instrumentation, I think there were a couple of times I really tried to push it too much, and that's when I had, I think, 2 or 3 varices as a result. But the instrument Lapidus, I think if you follow the steps and you're really, kind of checking everything as you go, it really does a good job of keeping you out of that trouble if you kind of go in a succession of order.
Scott, were you going to run this video? Is that what you wanted to do? So essentially, it's demonstrating with the lag screw that you don't get any gap recovery. This is a staple plate construct. That's ice that's melting, that they essentially caused a gap. And then you can see as this goes, what happens with the staple providing constant compression.
I love that video. I think that just speaks volumes.
And what this portion of the video is showing is that if you don't put lock screws on both sides of your staple, and I don't know, were you going to show that portion, Scott? Because the plate will actually move on the unlocked screws about 1 millimeter.
Unfortunately, the locking screw portion of this video is not on the slide, but it is available on our YouTube channel.
Okay. Yeah, but it shows that the plate will migrate approximately about 1 millimeter as this compression occurs. So post-op protocols. For me, I'm still somewhat conservative. I keep them non-weight bearing for the first 2 weeks and then begin heel weight bearing at 2 weeks in a cam boot that progresses to full weight bearing about 4 weeks. And then transitioning into a post-op shoe. Anyone else is, as far as their protocols, have they changed with this instrumentation and what have they been doing? I know that Dr. Philbin referred to it a little bit.
Yeah, I mean, for me, I think that I feel very good about the correction and the fixation. I've always been a non-weight bearing for a month for Lapiduses, but I'm starting to change that. I mean, obviously it depends on the size of the patient and other comorbidities, and the wound is extremely important, but I'm starting to weight bear some of these in a boot as early as a week.
Yeah, I was going to say that before instrument Lapidus, I was when I was just doing crossing screws, it was 6 to 8 weeks, I think, like everybody else. And then when I switched to a medial facing plate and a dorsal compression screw, I felt a little bit more comfortable walking them around 2 weeks. And I'd say I've kind of stuck to that. Although intraoperatively, I do kind of stress these, and I keep thinking that I should start to convert to 1 week, because I think patients do really appreciate being able to walk a little bit sooner. And I do feel that this construct is certainly strong enough. And one thing I was going to say is my construct in the last 3 or 4 DynaBunions has changed a little bit. I now send a screw from the medial cuneiform into the intermediate cuneiform, and then in addition, I still use obviously the first to second metatarsal bolt. And I just feel like I'm doing a little bit better with that. And the other key thing about that bolt is it's really, really important to make sure you have the near and far cortex of the second metatarsal with that bolt. And I think Dr. Leland was saying that he does the fully threaded screw, and I think that that would be something that I would consider doing as well going forward.
Yeah, my post-op protocol is pretty much the same as everyone. And I had using screws, I had weaned down to 3 weeks of non-weight bearing. But I've weaned it down even further with the Lapidus plate on the DynaBunion, and I haven't seen problems with healing with early weight bearing. And as I think Jerry said, really patients have become so intolerant of non-weight bearing after bunion. They've heard the horror stories of, I don't want a Lapidus because I can't put weight on it for 3 months. So it's nice to have a system that enables patients to be early weight bearing.
Great. Thank you all so much for your input this evening. If we do not have any more questions from anyone in the audience, I'd like to thank Crossroads again and our entire panel for your participation this evening. We will
Thank
have
you very much.
Sure.
Yeah, thanks, everyone.
We will have this recorded version available on FootInnovate. And also I would like to let everyone know that on August 31st, we'll have another Crossroads webinar introducing Mini Bunion 3D. And Dr. Bradley Lamb will host a panel discussion on that on August 31st. So you can register directly on FootInnovate or you'll receive an email from me. So thank you all again and have a lovely evening.
Thank you.
Thanks.
Bye.
Thanks, everybody.
Good night.